Who will speak for you if you can't speak for yourself?
My father made sure that I knew exactly what he wanted and how he wanted to live his life.
On today's program, we explore a new model for advanced care planning, designed to make it easier for all of us to identify someone we trust to speak on our behalf in the event we're incapacitated.
On any given day, if I ask an adult, if heaven forbid you were in a car accident or had a stroke, who would you trust to speak for you if you were unable to speak for yourself? The vast majority can tell me who that is.
Naming a trusted decision maker today on the Hear Me Now podcast from the Providence Institute for Human Caring. Hello, I'm Sean Collins. Thanks for spending time with us today. Advanced care planning allows all of us to make important decisions about the kind of health care we want if we ever face a medical crisis. Mary Kingston tells us her father's story.
My father had been at the Lyric Opera House doing what he loved to do best, which was listening to the opera. That particular night, when he got up to leave, he passed out and collapsed on the stairs, and he was transported to this very prestigious hospital in the middle of downtown Chicago. He had pretty much severed his spinal cord when he took the fall, but he was fully alert and oriented, but on the respirator. One thing I'm grateful for is my father had made sure that I knew exactly what he wanted and how he wanted to live his life. And of course, when I saw him in that bed with all of the IV pumps and the neck brace and all of the equipment around the bed, I wanted to know, were there any other options, any other things that we could look at? And we looked down all of those roads, and, I spoke with him and said, this is a stabilization of your neck for a 78-year-old man, but you'll spend the rest of your life on a respirator and in bed. And you won't be able to garden like you love to do, or bake bread like you love to do, or make jams, or go out to dinner. And this is what you and Mom and myself and my brother talked about. When it comes to a point where there's no more to be done, what do you want me to do? It was the hardest conversation I've ever had in my life. And he said, I don't want any of this. I don't want to be on this. I want the tube to be pulled out. This is not how I want to live. Even after having that conversation with him, I was torturing myself, like, am I doing the right thing by taking him off the respirator and helping ease his way? Is there something I'm not thinking about? Because in the end, I thought I was making the decision. I talked to his primary care doctor. He knew my dad very well. And this primary care doctor said to me, Mary, this isn't your decision. This is your dad's decision.
Mary Kingston is the chief executive of Peace Health, Oregon. The fact that Mary's father and his family had the conversation about how he wanted to be cared for made a difference. But relatively few families have had that conversation. Advanced care planning is still often overlooked or avoided, even though it is a powerful tool for communicating an individual's wishes. On today's program, a conversation about some of the roadblocks to advanced care planning and ideas for increasing the number of individuals and families who can take advantage of the powerful way it empowers patients to make their will known when that information can be crucial. My colleague, Ira Byock, is the Chief Medical Officer of the Providence Institute for Human Caring. Edo Banach leads the National Hospice and Palliative Care Organization, and Nathan Kottkamp, healthcare attorney, founded the National Healthcare Decisions Day many years ago. Gentlemen, welcome to you all.
It's great to be here.
Thanks so much.
The three of us have, in recent months, been in some conversation about how frustrating it is that after, for me, since the 1980s, pushing this idea, we have made only slight progress. Despite all of the efforts, people aren't getting advance directives on file, what we used to call a living will or a durable power of attorney for health care. And I'll turn to you, Nathan. Why aren't we succeeding?
Part of it, I think, is the way that we do medicine in the United States is we're sort of always pushing towards the next possibility. It's sort of Hail Mary after Hail Mary after Hail Mary. And so we get into this mindset where we're always thinking the cure is right around the corner. And as a result, we end up doing ourselves a disservice because we don't plan for what we would do if the disease, the cancer, whatever it is, ultimately is too strong or powerful. And so I think we just have a bad vocabulary for it. I don't think we've got good mechanisms for discussing these things in non-clinical circumstances. And so that's a lot of what got us to where we are today.
I would just add that we often think about the issue of an advance directive as either a legal document. I mean, Nathan and I are both lawyers. I mean, that's our instinct, or a medical document. And I think the reality is that if it's done right, it's actually neither one of those things. It's an articulation of someone's wishes that should come way before we're thinking about legal documents that deal with end of life, and way before we're actually thinking about receiving medical care. The reason we're in this situation is because we've either referred to this as a medical or a legal issue, and I think in reality it's that, but I think it's more. One of the things that's been laid bare by COVID-19 is the idea that all of that the way in which your life unfolds is predictable. It's not, and we've seen a lot of people who were perfectly healthy before getting COVID-19 and succumbing to it.
I think one of the things that we've done a disservice is to make the document more medical than it is human. And by that, I mean, I think when people are creating a living will in particular, they think that they're supposed to give instructions about their health care. And I'll tell you that most people don't have a good crystal ball. They couldn't tell us what kind of care they're going to need at the end of their life anyway. So having a bunch of medical instructions is way less important to me as one of the folks that has to interpret these than getting some guideposts about what does a good death look like? What does healthcare mean? What does it mean to be able to have physical contact and to be able to taste things and swallow on my own? Those are maybe healthcare, but there's so much broader, there's so much deeper. And so that's, I think, the reason why it's legal and yes, it's medical, but it shouldn't be. It should be something much more human.
Let me give it a name. I think these are personal documents. These name what you value, what your choices are as a person. And so I totally agree with your analysis. We tend to dichotomize things. That's how we deal with social problems in America. If you want something funded, you either have to call it a medical problem or a criminal justice problem. Those are the two mechanisms we basically have. And in this case, they're both partly right, but they don't encompass the essence of the thing itself. Illness is only partly medical. Illness is intensely personal, right? And we all know that. In I guess it was the late 1990s, Joe Finns, the great medical ethicist at Cornell, wrote an article in which he pointed out that advance directives are contractual, and contracts by design are intended to protect a person from threat, some risk. And yet people, as patients, when you ask people, how do you want your decisions made about your care, they want them made out of trust, in a covenantal framework, not in a contractual framework. And so I think part of where we've all come, frankly, is that we realize that we need to sort of start shifting both how we design these conversations and how we record the outcomes of those conversations. Maybe we're actually inadvertently in trying to, foster self-determination and autonomy. We've actually impeded the evolution of the therapeutic model.
Well, I think you're absolutely right.
So I think that the question for us now that we've all sort of denounced the over medicalized, over legal version of this is if someone were to give us a sort of a magic wand and say, all right, create this new world, what would we do? Because I think we have a chance, the three of us plus all the listeners, to actually push for something that works better.
Yeah, there are several ways of moving forward, frankly. Let me start by saying that within the Providence Health System, we several years ago now realized that we weren't getting anywhere. We were putting enormous time and energy, and our rates of adults with advanced directives on file are like under a third, and it is very frustrating. We recognize that their barriers were frankly two things. One, this sort of menu of specific treatments that are part of many of the legal documents that you are asked to pick from this menu of CPR and mechanical ventilation and all that, and people don't know what to do with that. And two, we require people to have witnesses or notaries. That's what the statute says makes it a legal document. And you can't even ask for witnesses from even our volunteers. The staff can't do it. And you have to get people from a waiting room or the next room in a hospital, family members will come over, or a notary, which are often few and far between when you need them, and may be expensive for people, by the way. But the other thing, what we recognize that the strength is, on any given day, if I ask an adult, if heaven forbid you were in a car accident or had a stroke, who would you trust to speak for you if you were unable to speak for yourself? The vast majority can tell me who that is. And that we could record, at least for their verbal expression. Most of those people can also tell me, in general, what they would want that person they just named to know about their treatments if they were seriously ill and their life was threatened. Those two things we could capture, but we didn't have a format for capturing them. So we created this thing called the Trusted Decision Maker documentation in our electronic health record. And we went all the way through governance to have that policy approved, that if a patient told their doctor or their nurse practitioner who they would trust to speak for them and in general what they would want, that could be recorded in the electronic health record. And if there was no advance directive on file, it could be used to guide choices of who to speak to and treatment options. Edo, you I think came up with the other option of having people simply record, do a video selfie about who they would trust to speak for them and what they would want, which frankly has like real face validity of being a clear document of people's wishes.
Well, I stole that from Nathan Kottkamp, but I think that that idea. I mean, there are obviously a lot of folks are on their iPhones all the time, and yet there's no easy mechanism. There are, but they're not widely used for us to indicate in a very simple way. I'm Edo Banach. Today is August 17th. God forbid if anything should happen to me, this is what I want. There's no easy way to do that, to document it. And further to the point, there's no easy way to make that a routine part of what you do. If Amazon suddenly said, in order to be an Amazon Prime member, you have to tell us what your wishes are. Or if when you get your driver's license or when you register for selective service or something, if there were a condition of something else that made this a routine thing, not something that happens when you're dealing with, do I need a ventilator or not, and you're in the hospital, that's too late. If it's something that happens way earlier, then we're going to see compliance with that go way up. And again, from the human perspective, we're not talking about medical anything. We're just shopping for food here, or we're just getting a car here, or whatever it is. I think that will help get more people to execute advanced directives.
I want to go further on this. I say within healthcare, we're trying to say it's like the allergy list. And we're saying that to doctors and practice managers, but we're also saying it to patients and families. This isn't about whether we think you're going to survive or we're worried about your health. This is about completing your healthcare record. I can't go further, in treating you without knowing whether or not you're allergic to some medication I might give you. I don't think you're going to have get anaphylactic shock, but it would be irresponsible not to have asked. And so we're trying to normalize it in that way. But, you're talking about even beyond that, just And they're not mutually exclusive, by the way, of having your driver's license, for instance, require that. Or, I think, Nathan, we've talked about your welcome to Medicare visit. I mean, in order to sign up for Medicare, that's a legitimate thing for Medicare to require.
Yeah, I couldn't agree more. I think I really like the driver's license option. I think it's elegant. It is something that everybody knows they're going to be asked about organ donation anyway, and these things sort of go hand in hand. But think about things like in the United States, we have health insurance. Why aren't we asking and reminding people as they go through open enrollment every year? Hey, this is a good annual time to revisit your designation of your decision maker and make sure to have a conversation with that person. You could make it a giant push to be done on your birthday, Thanksgiving, the holidays, and so there's other places that we could put the emphasis on this that will help remind people that it's not a medical thing, it's not a legal thing, it's a gift thing, it's a human thing, it's an interaction relationship thing.
And that could be, for all of the hurt and the pain that we've seen out of COVID-19, a silver lining could be that we finally begin to have these discussions in a more proactive way and document them. A day or two before, my mom called me apropos of nothing. And she said, these ventilators, they don't seem like they're working. And, prior to COVID-19, I would have said, I want a ventilator. In fact, she had an advance directive and she wished for a ventilator. But in the context of, I have COPD now, I didn't then, and I'm not so sure I'd survive on a ventilator in COVID-19. I think that I should update my advance directive. And I said that I agree, and I'm her proxy, and she was telling me this, and it went exactly as it should, which is not always the case, with family members. What that shows is that even if you think you have it all figured out, even if you've done everything right, circumstances can change. Your circumstances can change, or a disease can change, and suddenly what you thought you wanted is no longer what you want. So not only do we have to have a way of documenting this, we have to have a way of continually coming back to preferences and wishes and making sure that people are updated to make sure that that the gift that's been given is updated, so that I'm let off the hook. I now know what my mom wants if it ever comes to it. And that's the point I was trying to make there.
Yeah, absolutely. And I think it also highlights the importance of having these conversations, having the documents, having this entire process be much more values-based than instruction-based. And the reason I say that, I know plenty of people who have an advance directive, they've got that living will, and it has phrases that would be, I always want this, or I never want that. And so we've got people that have an advance directive right now that says, I never want to be on a ventilator. And the reason they say that is because they saw someone in their family or their loved one go through terminal cancer, and that's the vision that they have of the ventilator, right, as opposed to 48, 72 hours to get through the critical stage of COVID. They probably would want a ventilator in that circumstance. Not everybody would, but if you were to describe to your decision maker what your perception of importance in life is, what does it mean to recover, what is it, sorts of things, that's actually more valuable in that kind of circumstance than having a document that says never ventilator, because then you say, wait a second, does this person really want to die? We think there's a chance that they're going to live. So I think all the more reason to try and make it less specifically prescriptive and much more broadly descriptive of what your wishes are.
We tried to build in just those two things, making this more covenantal than contractual, and then giving a sense of your values and priorities to whoever was going to be reading this years hence, hopefully, and we'll have to, the person you named or your future physicians, to give them a sense of what you think you would want in those circumstances, rather than a specifying the menu of the a la carte options, which as a physician feels absurd. So often in the past, when I was a primary care doc, I would give people an advance directive to take home, and they would never come back. And it's partly because when you get to that stage of, well, do you think you'd want this treatment or that treatment? People look at you and say, I don't know, I got to talk to my family about it. Somehow we need to change this up.
There's also a sense that when you get that laundry list of the living will, that there's some existential dread that it calls up in anyone who's reading that. Yeah. It's like it's a scary thing to imagine yourself in each of those situations, and it's a scary document to have to go through and try to imagine yourself, what would I want in that situation? Whereas it's a much more humane approach to say, you know what, my son, I trust to make this decision for me.
Yeah, and that's where I sort of come down as an individual. I mean, all this is such a, very specific to who you are and what your values are. But for me, I don't want to start dictating to anyone a number of different scenarios that really, even though I think I understand, may change. So I would rather, and this is what I've done, just name my brother to make a decision and say, look, I trust you to make whatever decision. I won't even know probably what decision it is. Go for it. And I'm letting you off the hook. I'm letting you know I trust you fully. We've talked through the years, generally what my wishes are. If I try to be specific about what my wishes are, it's going to get it wrong for the reasons that Nathan articulated. I may say I don't want a ventilator, and in fact I do. I may say I do want a ventilator, and in fact I don't. I think it's better to just name somebody, which is why what I advocate for is at least have a healthcare proxy.
Absolutely. Let me just defend for a moment those who want to give some direction to that person. I think for families sometimes having some sense of whether people would want everything possible to keep them alive, even if they were unable to recognize others or interact, or they would not want anything and would really just be wanting to gently leave this life, take some of the burden off of the person you've named shoulders. And if you can't do it and you really trust them entirely, that's legitimate as well. Just saying that, as you have. But the burden that people feel is really great. And if you can give them a sense that they're making this decision on your behalf, it may lighten that burden just a bit.
I think as the younger brother, I want him to have that burden. It's the last laugh that I get as the younger brother. No, but seriously, I think that your point is a good one. These are often difficult family dynamics, and you empower one person, and the other three sisters are going to be mad at that one person for the rest of their life if they don't agree with the decision. So I think you make a great point.
I've actually written into my document, if you're needing to read this, it's likely this is a very stressful time for all of you. I want you to know that what's most important to me is that I trust the decisions that you will make, and that that I want you to support one another and be loving and patient with one another and yourselves during this difficult time.
That's Dr. Ira Byock, founder and chief medical officer of the Providence Institute for Human Caring. We're also joined by Nathan Kottkamp, founder of the National Healthcare Decision Day, and Edo Banach, president and CEO of the National Hospice and Palliative Care Organization. When we come back, I'll have details for you to get more information about the Providence Trusted Decision Maker tool, and our conversation will continue in just a minute. Stay with us. This is the Hear Me Now podcast. I'm Sean Collins. If you'd like to take a look at the Trusted Decision Maker form that we've been talking about, Visit us online at instituteforhumancaring.org and click on the Advanced Care Planning tab in the blue menu bar. Again, that's instituteforhumancaring.org. Back to the conversation with Ira Byock, Edo Banach, and Nathan Kottkamp. Nathan stresses how crucial communication is when completing advance directives.
One of the things I think is absolutely critical, and it's a step that does get forgotten sometimes, is you got to let the person know that you're actually naming them as the decision maker. Mm-hmm. The vast majority of the time, the person will rise to that challenge, if you will. They'll be happy to do it. It's not an easy task, but you will come across a certain percentage of people who say, I just can't do it. One, maybe they disagree with the choices that you make in life, and it'll be challenging for them, or maybe they're just highly emotional folks, and they'll be the person by your bedside every single day that you're in the hospital, but they're not going to be rational decision makers. So just make sure that you are making that request, and so that it's not a surprise to someone.
Gentlemen, before we conclude, I have to ask you both, since I have now two nationally prominent attorneys with me, what are we going to do about the statutes that are standing in the way of real reform in many regards?
Well, I've got one answer. It's not an easy answer for my colleagues, and it wouldn't be easy for me to give the advice yet. But I think I can sum it up by saying we need lawyers around the country to be brave. When you look at most of the statutes about, first of all, creating an advance directive, the statutes tell you what you do, the steps you have to take to create a valid advance directive. They don't tell you that you can't take something short of that. They will provide you immunity if you follow all those steps. And so the way that gets translated into defensive medicine is, we're not going to take it if it doesn't meet those provisions. But we have to bear in mind that there's also community standards of care out there. And so if you take a particular community or an entire state, or ideally the entire country, and all the hospitals say, well, if we have it recorded in our medical record, it was declared before two nurses, a nurse and a physician, whatever the thresholds are within a particular institution, and we consider that to be valid. There is no question in our mind that this is a valid expression of a person's wishes, and we just go for it. We will have actually created the standard of care. We'll sort of put it outside of the particulars of statutes in a state. So that's one way to do it. That's extra legal, if you will. It just doesn't require all the mechanisms. Similarly, if we get insurance companies to do it, if we get insurance companies to say, we are going to not pay you, or we pay you some lesser amount if you haven't obtained a designated decision maker. Medicare could do that. Private insurers could do that. So there's other ways of getting around those. And I think if we were to do that, then the state statutes will probably get tweaked accordingly, so it doesn't seem so inconsistent.
Yeah, I would agree. I mean, I think that I'll key off of that last point that Nathan made. I'm very much a federalist on this issue. Yes, we defer to states, and states get to determine these rules, but there's nothing that would prevent CMS from, through Medicaid and Medicare, requiring as a condition of payment that individuals have and enter into an advance directive for Medicare Advantage managed care plans, for Medicaid managed care plans, and I would argue for commercial Obamacare plans as well. Now, the mechanism for doing that is complicated, and a bunch of lawyers will yell and scream about the fact that it can't be done. But I think it can be done, at least to create that standard. If a state wants to become more strict and require bells and whistles, they can do that. But right now, we don't have that federal default in terms of the insurance companies being directed to do something, and I think we could have that.
One other state-based strategy might be to insert a single line into the state statutes that acknowledge in the beginning of the hierarchy provisions that a verbally expressed wish documented within the electronic health record by a patient who has capacity to make decisions about their future preferences will be acknowledged as evidence of their wishes.
And I think we need something else. We need the threat of the conversation of death panels or fights with the church to go away. I mean, we really need to have an upfront, honest discussion that says, look, what we're talking about here are personal wishes of individuals to receive the care that they want at the end of life. And sometimes if you're talking about dementia, obviously the provision of care itself is something that has to be consented to. And so we do need a lot of the political rhetoric and the religious rhetoric to allow a more streamlined process to work its way through. And I think that that's going to take leadership, and I think that that's going to take courage as well. But that's what I hope we can get to.
Is anybody pushing back on this idea?
I don't hear much pushback, frankly. I hear a lot of people, popcorn fashion, coming to the realization that the way we've been doing things over, the last 40 or so years isn't working. That we really need to start to innovate and look at other ways of capturing people's legitimate expressed wishes.
What I've heard, and I think it's not helpful, is none of this matters. We've been spending 30, 40 years talking about advanced directives, talking about people's wishes, and it really hasn't worked. So let's give up. I think I take the exact opposite message from that, which is, no, we've been doing some things the wrong way, and let's work on doing them the right way and making sure that people are getting the kind of care they want. We certainly shouldn't kind of give up and say it doesn't matter. It matters profoundly.
Well, I think we also have to recognize that there are going to be folks that are resistant or at least concerned. There are racial and other minority issues where there's concern that if you name someone, you are effectively giving up your right to make choices about yourself, even though it doesn't work that way. This is the default. This is if you cannot make decisions for yourself. Disability communities, advocacy communities for whether it's dementia or Alzheimer's, we oftentimes see when we're working on these projects concerns that by naming someone as opposed to leaving it vague, it gives an invitation for the medical providers and others to jump to that individual before they should, and that there's some period of time where the individual ought to remain their own decision maker. So we have to be careful about that. I do think those are some of the places where we can see some pushback. But if the way that we approach this is as a mechanism of honoring the person's wishes, not as a mechanism of taking away their ability to decide for themselves, it's a continuation. We would love to get your instructions right here and now, but you don't have that capacity. So who's going to pick up the mantle and run with it for you?
Yeah, and where there's also radical agreement is that those decisions, if they cannot be made by the person himself or herself, should be made by the person who is named by that individual, that person trusts. I haven't heard any criticism of that. Who else would have more standing than the person who is trusted? So I guess my question would be, are there next steps?
I would like to see less laissez-faire, a little more muscularity on the federal level in terms of what insurance companies are required to do. I think that's a very solid, very specific thing. The Welcome to Medicare physical as a baseline of what individuals' wishes are, that should be non-controversial as well. So my mind goes to what policy can we institute at the federal level that would begin to sort of chip away at this?
And for me, it's first and foremost, try and get it out of the medical system, try and get it away from old age. So whether it's, and these are not ors, this is probably and, the driver's license, the annual signing up for your health insurance, those types of things where National Healthcare Decisions Day, I can't forget that one, right? So these mechanisms that on some periodic basis that have nothing to do with healthcare specifically, we're being reminded. And then within the healthcare context, it should be in every patient, every time, every interaction.
I'll just conclude as a doctor and say I agree with all that. And as a both and, I'd like to see it become an expectation of normal that every adult patient has their trusted decision maker in some way acknowledged within the electronic health record, that is front and foremost part of the personal information that is part of the opening page of every patient's electronic health record, so that you know that information, and that it be refreshed, if not at every encounter, then at periodic times of maybe the annual visit, or however often one sees your primary care doctor, but at times of new diagnoses, deaths in the family, significant change in your marital status, or any sort of significant life change. It's simply routinely refreshed and revised as necessary. And then I do think we need to create some sort of a national template, a uniform statute that the states can use to just make these more personal and non-medical approaches legal, and not actually inadvertently put barriers in people's places.
Gentlemen, thank you for a really fascinating conversation. Really great.
Thank you so much.
It's great to work with you to change the world.
You too. Always. Thanks for having us.
Dr. Ira Byock is the founder and chief medical officer of the Providence Institute for Human Caring. Nathan Kottkamp is a healthcare attorney and founder of the National Healthcare Decision Day. And Edo Banach leads the National Hospice and Palliative Care Organization. For more information on the Providence Trusted Decision Maker tool, visit instituteforhumancaring.org and click on the Advanced Care Planning tab. Hear Me Now stories are edited by Allison Jakes and Mike Addis and produced by Scott Acord and Melody Fawcett. The executive producer is Michael Drummond. Hear Me Now is a production of the Providence Institute for Human Caring. Write to us at humancaring@providence.org. Our theme music was written by Roger Neal. I'm Sean Collins, inviting you to join us for the next Hear Me Now podcast and to subscribe wherever you get audio on demand. Thanks for listening. Be well.